All right, everybody. Dr. Jeff Rody here. So glad to have you all on another Viva Learning webinar. Thanks for joining. I know a lot of you probably had a busy day too, and different time change things. Of course, I'm always appreciative of the chance to just kind of share some of the things we do every day. I mean, really, these webinars, why I love doing them is it's kind of a story of what we're doing in our office. This is at a very basic level, we're doing periodontal surgery, periodontal care, and I'm going to show you some highlights today of that, including a new handpiece that's out for Celea that does minimally invasive perio surgery. It's amazing stuff. And the encouragement I always have is, hey, if you're a periodontist, I think there's some good research and reasons behind using this kind of stuff. And to encourage you, if you're a GP and you're not doing this, this is a platform that provides a great onboarding experience to adding some of these more straightforward procedures in your practice. Something that right now probably sounds daunting is actually not. I'll go into this a little bit later, but one of the things that I love about the company as a whole is they are very committed to training. So everything you see today has classes and online work and in-person hands-on things that show you how to do each of those things. So I'm excited to share with all of you. For those of you I haven't met, I'm a general dentist. Oh, I see a typo already on there. General dentist in Santa Barbara. Went to UCLA, go Bruins, and then basically now we have kind of a high-tech practice where we have used a lot of technology, including lasers, to kind of improve the patient experience and improve clinical outcomes. And so it's been a lot of fun to integrate Soleil into what we do. Really, for those of you who haven't heard of it, you can go back on the Viva Learning website. There's a few different ones that show everything from restorative procedures to surgical procedures. It was the last one we did. Basically what it is an all tissue laser. So basically look at it this way: no numbing, no drilling for fillings. It's amazing for kids and adults. We haven't had to numb a child up for a traditional filling in over 10 years, so it's been pretty amazing. But it also cuts tissue and bone, right? And it does so without bleeding. And some of the newer applications that we have in the last couple of years is one that treats snoring. It helps to contract the collagen in the soft palate to kind of vault that up to create a better airway. And now what we're going to be kind of focusing on today is more of the periodontal techniques with that. Just as a little quick preview for that, then I want to show you what this kind of looks like in there as far as what it's actually doing. This laser cuts tissue nice and smooth, no bleeding. In this case, we're actually doing that to create a little access way into the rest of the decay there. I'll talk about some limitations of that, either how you want to be careful for where the attached keratinized tissue is. You don't want to cut away if you already have a little recession there, but otherwise widespread use in the mouth. Then end cutting, you redirect it toward the tooth, pointing at the tooth, it's going to cut. You see it removing composite nice and smooth, works on decay, works on dentin, decalcified enamel, everything. And this is why it becomes truly all tissue, because basically if there's a component of hydroxyapatite or water or collagen or plastics, it's going to cut it. So it covers a whole host of materials, but that absolutely covers the actual like tooth structure, bone, gums, all of it, right? Now, the thing that is my favorite thing about laser dentistry is where you see here, like this is just a few days later, and that's the kind of healing that we get and expect. Everything the laser touches heals faster. I'll give you an example that I often use is crown lengthening. When I was in school, we had to wait, we were told wait 6 to 8 weeks before you take a final impression. And with that, you got to kind of put the patient on hold. This healing is so fast that a lot of times we'll either go to a final impression that day because it's predictable on how it's going to heal, or we might wait a week at the most if we did a flapped crown lengthening procedure, but that's really all you need for that. And that I have we are going to touch on crown lengthening a little bit today. I would encourage you also to go back to that last Viva Learning webinar where we actually do a deeper dive into laser crown lengthening with that. So, but this is the kind of healing you can expect there. And this is why it's kind of different. You saw how smooth it was cutting that tissue. Just kind of comparing some techniques here, right? Um, when you go in with other lasers, the idea here is that the laser energy is being absorbed into water. And the 9.3 micron laser happens to fall into a wavelength where it's absorbed by water, but not vigorously. Part of the reason why we see the erbium cut the way it does is that you're kind of dotting along, but it's a very explosive cut to water. That's essentially how it's cutting teeth. Is you're not really cutting teeth, you're exploding water and launching chunks of the enamel off. Well, in this case, for example, what you saw there was a nice, slow, smooth cut. Essentially, you have the capability and control to cut one cell layer at a time if you want to with this laser. So what ends up happening is rather than kind of hole punching, this is more like sculpting and something more akin to festooning. Let's look at one more example of that. The case on the left is doing some troughing around a tooth with erbium, and the case on the right is where we've done an implant uncovery. You notice how clean and smooth that tissue looks, no bleeding. This is totally ready for a final impression. And that's the kind of healing you can expect too. I use, we're not getting into implants today, but I use the Celea 9.3 micron CO2 for any incisions, punch cuts for implants. I use it for implants for the first punch through bone, through that cortical bone, the one that makes it really kind of hard to push sometimes, that first drill through. This is all takes the place of all those things. So recently, I had a case where we actually wanted to do a slight revision to a gummy smile treatment. And she actually had the procedure done twice before, a few years ago with erbium, and then a few years before that with traditional flap surgery. And she actually had a couple, I'm going to show you her case in the video of that, but she actually had a couple pictures left over, right? So this was basically flap surgery. This is, you can still see there's a little bit of sutures in there. So this is probably about a week out from that she took the pictures for. And then kind of fast forwarding a little bit, this is 6 weeks after surgery. This is kind of the traditional method for, again, you're going to flap everything, suture all those papilla back, and now you're kind of treating it that way. Then a few years, so you can see even after 6 weeks, this still has some progress to go before the tooth is and the gums are actually there. Second was then erbium, where this is even 3 weeks after surgery, and there's still some inflammation because of that kind of destructive cut in there. So let's look at just kind of, as we start getting into thinking about like how we're going to use this for perio surgery, we're going to be mostly talking about the new updated handpiece that's now available that does minimally invasive. But, just so you all know, we actually do traditional flapped perio surgery with this because it cleans up the granulation tissue so well. And so here's that case. Let me hit go here. I'm going to kind of jump us forward here. I've already kind of done a little bit around number 9, the upper left central incisor, and now we're going to kind of do a little bit around number 8. And the whole goal here is to kind of peel that back, and you'll see me just reposition the camera a little bit, the microscope a little bit here. But the whole goal here is to peel that back, and this will actually remove any thin alveolar bone right along that edge. Again, it does it with no bleeding. I'm striping right along that tooth. You'll see where you kind of expose the composite edge. And I can kind of almost kind of flare that back a little bit. what you're seeing here is one handpiece that's available too. It's kind of rather than a contra angle handpiece, it's a straight handpiece, which is great for procedures like this because you get to see almost like you're airbrushing, right? And when you see a little bit of where it's cutting right now, and there's a little bit of a plume, you can see where it's actually cutting bone. The plume's kind of that little bit of a flash. So I'm actually cutting back both a little excess alveolar bone plus the actual gum tissue itself, right? So basically a little right there, especially right there, a little laser crown lengthening based on that. And you just look at how clean this cut is with no bleeding. And then you'll see me kind of go across the top just to kind of flare that out a little bit. Um, what we did after that is kind of fill that back in with composite to kind of do this. And so here's 4 days afterwards. Um, and we already see some generous healing there. Number 9 is pretty much almost all healed. Number 8, where we did a little more aggressive work, and 7 still has to go a little bit farther, but almost there. And here's basically now fast forward just a few more days to 1 week, and look how good the healing already looks on that. So this is why this categorically cuts better and heals faster than any other tool we have in our arsenal as far as dentistry is concerned. And to encourage you, just to dip into ROI just a bit, for y'all, this still has to be, if we're all CEOs of our own office, um, as Doug Fedek would say, you got to kind of think about, is this worth it? Side note, by the way, while I'm thinking about it, don't forget we do have the Q&A button there. If you need to ask any questions, we are going to share some Q&A time at the end, but feel free. I'm monitoring the questions as they come in. So if you do have anything or any questions about what we're talking about, please definitely use that. So just thinking about this, right? Okay, so how long does a typical numb it up class 1 take? You just look at, part of our return on investment is efficiency. And with that, what are these procedure times? Well, you saw how that one case that I just showed you, closed crown lengthening 5 to 10 minutes. It just doesn't take that long. And even if we did flap it for whatever reason, there's some indications for that, which we'll talk about a little bit toward the end. Well, we're still talking about under 30 minutes. Same with pocket reduction surgery, 30 minutes per quadrant. Compare that with traditional perio surgery or crown lengthening, it just takes longer. So you'll be able to get more done with your day, but then you get a happier patient because you're healing faster on top of that. So this is where the benefit to your practice starts to settle in, is that you'll be able to handle more cases and have great clinical outcomes from that. So that's our business moment. Let's get back to some clinical stuff here. And here's the difference now. Here's the new perio guide from Convergent Dental. It's a handpiece that sits on the laser. It's an add-on that basically it's a little software update on the main machine. They ship you the handpiece and you're off and running. And what we use this for is basically minimally invasive periodontal care. Think intra-pocket, non-flapped perio surgery, closed crown lengthening. You could also kind of use it around extractions. Now, if some of you Solea owners are on our webinar here, I will say that I still use the contra angle all the time, and I'll point out some of the areas where we kind of like, well, which one do I use and where and how much, and we'll be talking about that toward the middle of the presentation a little bit, so you can kind of get an idea of that. Because even though this thing's been really fun, I still use the contra angle all the time. But this is kind of what we're using it for. This is what the actual handpiece tip looks like. So you attach this to the machine. That gold little disc at the top is actually internally a mirror that bounces the beam down, and it goes right through that little tip. It looks like almost like a little perio tip, but that perio tip is actually hollow. The opening is 0.25 millimeters wide, and the galvos, little turning mirrors in the laser basically direct that laser beam perfectly right down that tip, so that you can drop that into the pocket or around implants, and deliver that energy there. And it's kind of marked like a periotip. Basically, the markings are at 1, 2, 3, and 5. You can access in there. When it comes to indications for this, we're really looking for something that is, kind of that sweet spot is kind of the 4 to 8 millimeter pocket, depending on inflammation levels. So the 7 millimeters kind of works great. If you're at 8 or beyond, that's where we're kind of rethinking either potentially extraction or traditional flap surgery for pocket reduction surgery, just to make sure we're reliably getting in there to do that. Um, but let's kind of go through just a little bit, just as a refresher, like how much are we, you know, it's like, is this going to be a common thing we see? Do we need to, like, is this like, oh, hey, this thing cuts fibromas, and then someone will say, oh, I haven't seen a fibroma in the mouth for like 4 months. Well, let's think about periodontitis here. And these are real statistics here. Basically, we're at 42% at age 30 years and older have periodontitis, and 7.8 have severe. Same with over 65. So I kind of put all this into a table just to kind of show you. So essentially what this is saying is as your patients get older, it's more and more likely they have it. More than half of people over 65 have periodontitis, of which 10% of that, the 9% there, are severe. So we're talking about severe bone loss and bleeding on probing, all the classics. Um, when you come and when you start to think about the impact of that, it's like, well, how come we're seeing such a prevalent amount of this? And what we know is that there's a lot of causes for this. So chances are in your practice, you're thinking, okay, well, where am I going to use this machine? Well, potentially half of the people over 65 or, a good third of the people under that are going to need something like this. And because here's what we know, right? What are the risk factors? What sets this off? Well, pregnancy with gestational gingivitis, at least you have some kind of potential return to a normal state with that, right? But that is, unchecked, that can lead to periodontal disease, diabetes. I had someone one time say the best way to think about diabetes is it just takes out your immune system. Just kind of just corrupts that immune system so it can't fight against it. So inflammation wins out more often than not. Smoking, we know that one cigarette cuts the circulation in your mouth in half. And all, of course, then leads to all kinds of problems with inflammation related to that. And drugs of different kinds, of course, can lead to that too. So you start to then look, okay, well then that's the how. Well, what's the effect? Well, we all know in dentistry the effect goes way beyond that. The oral systemic connection is well known to us, and thankfully the rest of the world is kind of trying, kind of finally figuring this out. But everything from cardiovascular disease to actually worsening diabetes, now we have confounding, factors here. And of course, respiratory, actually inhaling these pathogens. Forgive me, I forget the name of the podcaster, but I heard it described one time, even for gut health, is that imagine, going to a creek around your neighborhood with like kind of somewhat dirty water in it, and then scooping that up full of bacteria and then drinking that every day. And it's kind of gross, but when you when you think about it, excuse me, when you think about it, that's kind of what you're doing when you have active periodontal disease and you're manufacturing and shedding bacteria on a regular basis. That's all going down into your gut, and that's causing all kinds of problems too, much less your circulation. So this is a real thing, and it's a real problem. And the beautiful thing is you all can make an impact on it. And probably the scariest one to me is the connection to brain health, where basically they see systemic inflammation in the brain of these bacterial pathogens that could increase with dementia risk and cognitive decline. So if that's not scary, I mean, I definitely think we have some work to do then for these patients that can help them out. So let's look at what we're actually doing here in that case then. So without getting too much back into the dental school weeds of we have different grading and all this stuff, and how the different bacteria start to affect that. Just look at it as like, hey, bacteria in there's granulation tissue. We need to get all that stuff out, right? So when you start to look at the goals of treatment, then number one on there is get rid of the offending factors, right? Reduce the bacteria, and basically kill off the bad stuff. Second thing is inflammation control. Basically, the idea then is once you remove those factors and clean it, we're now going to have basically a stimulation. You're going to have, basically the idea is this idea of photobiomodulation, where you're kind of stimulating the cells to want to heal. And then the idea is to reduce the pocket depth, get clinical reattachment, and generate actual new bone. And I'm going to be sharing a study that was done that shows actual new bone formation after using Celea in the pocket like that. So that's the goal. It's more than just kind of cleaning, like a diode. If we're just trying to get, or a Restin, right? We're more than just trying to just kill off bacteria. We're actually trying to sort of kick off a healing response and initiate that reattachment in there. So we're going to take a 4 to 7 millimeter pocket and turn it into maybe a 3 to 4. Right. That's the goal, is healing from this. And this is why we love it. It's you're removing granulation tissue, killing bacteria. It'll wick calculus right off the side of the root. You actually see that bubble up out of there if you have some subgingival calculus, and so on. So now the way we're actually doing this is a pretty standard recipe now. And I'm going to show you this slide, and then we'll kind of do a deeper dive into each one of these. But the first thing is kind of figure out where you are. When you come to training, we actually give you, if you're not doing these things, we help you with all the coding, all the CDT codes, how to bill to insurance, how to say, well, when do I do my gross debridement, and then I do my root planing and all that. We'll go through all that. But when you finally get to a point where you show some unresponsive pockets, then here's where the Perio Guide comes in. And what you're essentially doing is lasering first to remove the diseased tissue. Then you go into a mechanical scaling. Ultrasonics or piezos, electrics work great for that. And then basically really kind of sort of with tactile feedback, clean that surface, which then helps to detoxify everything. You'll go back and laser everything out, and then let everything heal up. You don't probe for a few months, and then hopefully you actually get that bone growing back. So let's do a little deeper dive in there. So let's see what this looks like. I mean, obviously, stuff like this, you want to get the big chunks off. I apologize if any of you are at home eating dinner while watching this, but yes, you want to get in there and start exposing things. That alone is going to start helping reduce inflammation, which is the name of the game here. And then, of course, figure out where you are, figure out where bone levels are. I always cross-reference with a CT scan. Bite wings work pretty good, but they, as far as the overall levels, sometimes you need to switch that to a vertical bite wing to really see where the bone is, depending on how much recession has occurred. But a CT scan is a great way to look at a three-dimensional view of where the bone is, because I use that to kind of plan out where my laser is going to go, what bone is going to be reshaped, and that kind of thing. And so basically get all the big chunks off, like we said. Before you jump in with Perio Guide. Next up, go into the pocket. Basically, you're firing that tip and you're kind of sort of blunt dissecting away. So you're between the gums and the tooth. and you just kind of sweep. Imagine going about a millimeter in and then sweeping around that cuff, and then you drop in a little more and sweep backwards around that cuff, and then drop in a little more and sweep until you basically get to the bottom of the pocket. That is the protocol. That's it. And by doing that, what you're doing is actually going and vaporizing basically the granulation tissue that's preventing reattachment and a harbor for that bacteria. It's just kind of exposing new skin kind of thing. And so you go back and forth. Then after that, so you're timing wise, you're only doing about 20 to 30 seconds, not more than that per side, per tooth. Yes, we would treat the lingual and a quadrant. No, I don't think you need to treat everything in the quadrant, only the affected areas. Like if if the in this picture, if the canine is a twos and threes, you're just skipping that tooth, even though it is a quadrant fee. So just stick with the areas that are kind of four and above and not responding there. And you're just guiding that through. That's it. Then go in and do some scaling and root planing. For doctors, if you want to kind of step out of the way, let a hygienist do this part or just do it yourself, that's easy. But basically, I want to know that mechanically that stuff's all out of there. Um, Side note, the video I showed you with the class 5, where we were doing the cavity preparation and a little bit of a gingivectomy there, that's done with no numbing, even the gingivectomy part. This is just to clarify, this is all with numbing in there. Um, okay, so so now we have everything cleaned up. It feels nice and smooth. Then what you're going to do is go back and relaze and deepithelialize, and this is kind of your last. Now that you've kind of stirred the pot, you're essentially going in there and just kind of sterilizing everything in one final pass in there. Um, and then apply nice pressure around there, damp 2x2. Essentially, when you've done this, what you've done is kind of ballooned out and opened up the pockets by putting that tip in there. So the idea now is you're going to kind of recompress and get that clot to form back down on there, um, and get that tissue nice and tight back on the roots of the surface. Um, Now, at this point, more of this then will be just any interferences, do any little final bite adjustment, and that should do it. I tend to do this more in the beginning of the patient's time in our office. This is kind of part of the initial diagnosis and treatment planning, looking for anything that is essentially kind of, if it's an occlusal interference, I'll handle that sooner than later. But you do want to do just kind of a final bite check to make sure the teeth you worked on aren't hitting too hard or anything, because that'll kind of obviously cause a little firmness and then poor healing, poor attachment gain. So, well, how do we know this actually works, right? Well, there's a study done from the Nevins brothers. Basically, they showed pocket depth in decrease over a 9-month period. They treated a bunch of teeth. This study, if you want to look it up, has actual histological slides. And not just we hope it grows new bone, but you actually see the new bone that's grown on that. So pretty awesome stuff when it comes to that. But I love that the study was done independently, because essentially, we need to know, okay, this might clean it up, but do we see long-term attachment gain, new bone growth, and stability in the periodontal ligament? And this is wonderful, because it actually shows that we have that improvement in there. So let me show you this video that just kind of shows this all kind of at work. So you're kind of checking all the pockets, you're figuring out where you want to go. In some ways, you're kind of planning your surgery. You can see where those pockets are around there. um, more than just having that basically be a simple measurement. This is kind of letting me know, okay, now here's where my actual perio guide is going to go. You can see it just kind of slipping around. When you see a brighter plume like that, it is either cutting bone or maybe potentially a little on the root surface, but it's not cutting the way it would that class 5. It's just, if anything, it's more cleaning the surface of that. And you're just kind of going tooth by tooth, doing that kind of sweeping motion back and forth, um, and um, and keeping constant pressure on the laser. Um, if you come to training, it's kind of fun. I don't know if you all have ever done a surgical class with pig jaws, but we actually try all this on pig jaws before you go home. So it's a great class. In that class, they cover everything from crown lengthening and extractions as well as some of the other stuff we're going to be talking about today. But here we are. This is basically the whole technique right there. Sweeping back and forth. The patient is, as I said, numb for this part, as we go through and treat this. Just because you are kind of down in there, same as if you would have numbed up a little bit for scaling and root planing. There are some patients who we've actually used a topical anesthetic, a compounded anesthetic. Think like ours is 20% lidocaine, 4% tetracaine, 2% phenylephrine. And we just basically put that in a little syringe with an endovac tip on it. And you almost kind of just backfill each pocket. And we get a lot of this stuff done without doing a whole true injection. So next up, you can see we're using ultrasonics to get in there and kind of clean around there. You're feeling for any little granules left or any little spicules left on there. And then just go back through, laser again. This is the whole technique. Um, and then you'll do your gauze compression after that. So now as far as armamentarium, you can see here too that you don't need any special curettes, or I mean, if you're not surgically set up, you don't need to go out and buy a bunch of other equipment. I mean, this tool is pretty much it. There's, if most people have some kind of Cavitron or something, um, but you don't have to. I mean, you can certainly hand scale this, and that would absolutely work as well. So, all right, I'm so glad that we got to show you guys that. That is the new Perio Guide handpiece that is currently available. So with the time we have left, I just want to kind of go through a couple things here where we show a few more applications for this. So starting with that, just keeping the ball rolling here, is things like a periodontal abscess. This is now more of, rather than treating a chronic situation, this is treating an acute situation. And in this case, we see kind of that periodontal abscess running down there. Of course, it's hard to probe these because you don't know what's inflammation and what's the actual pocket, but that's where you'll want to go in and kind of treat that either way. And in this case, you're doing a little bit of not just going into that pocket, but reducing some of that excess tissue away for cleansability. Now, at the beginning, then you'll basically do some kind of numbing, either infiltration or your compounded topical, and really kind of go down in there and clean that out. You're still applying the laser energy all the way to the bottom of the pocket, but by removing some of that kind of schmutzy overlying tissue, you're reducing the pocket just from a standpoint of accessibility. Then go in and do your closed flap technique with that to do it. And again, you have the same effects of being antibacterial and and really lets you clean that out. There is you saw in those videos, there is mist and irrigation, so it does help to kind of bubble back out. If there's stuff in there, it's going to kind of, turn around and flow back out. Um, Incidentally, by the way, just a shout out to Josh Weintraub for some of these cases. Amazing dentist. He's also one of the Celea trainers. If you're on the East Coast, you'll definitely look up his classes because they're fantastic. So he got in there, treated this, and then here it is after 1 month. You still see where that's resolving a little bit, but it's pretty much healed. Inflammation's gone. And then, of course, a 1 year photo that's completely smoothed out over. So incredible results. You can do INDs with this if you want. But you're not just cutting, you're killing bacteria is the coolest part. Um, so now, what is some of the limitations of some of the other lasers as well? We talked about sometimes erbium does too much of a jagged cut. Well, most of the other lasers are not safe around metal. You cannot cut or close to metal. Otherwise, think about hyperplastic tissue around braces or uncovering an implant. Um, so you can't use it around that. And one of the biggest things that we're going to be seeing in the next few years, more and more and more, is basically disease around implants. The two categories we're seeing is kind of basically peri-implant mucositis as well as peri-implantitis. And if you can kind of break it down a little bit, just the easiest way I look at it is peri-implant mucositis is basically inflammation around the implant without bone loss. So you haven't exposed threads. Peri-implantitis, you actually have vertical bone loss, dehiscence, some kind of actual exposure of the implant itself rather than just inflammation. So let's kind of show a couple of those cases here. So the first one here, peri-implant mucositis. Here's the situation where you see the double abutment of these two implants. They're essentially causing, just basically trapped food in there. I got to be honest, I don't love double abutting anything because of this exact amount. You just kind of made a frication that's almost impossible to clean. So even though this wasn't done, you do certainly have the option of, redoing the restorations. Maybe you're still utilizing the abutments for that, but we're going to show you just kind of how we cleaned it, but I would consider redoing some of the restorations on that case. So here it is at work. And you can actually fire and hit that implant. And the idea is you're not going to disturb the surface. You're not mechanically touching it. But if the laser energy can get to those threads, you're actually creating a situation where you're detoxifying the surface of that implant. So imagine if this was a full dehiscence on the facial of these teeth. You could flap that back rather than just a little localized inflammation. Flap it back, and the technique, and Dr. Scott Frome in New York has some papers on this where he proved that the implant was not damaged in any way, but you're actually firing into there, and that textured surface and the threads you actually want to fire the CO2 at those threads and at the implants because that's what's going to kill the bacteria off. So you're detoxifying that surface of the implant. And in this case, then we're kind of doing like a little bit of a mini flap to really get in there and get some of that granulation tissue out, that harbor for the bacteria. And then once that's pulled back down, that allows you to basically heal in that kind of not quite sterile, but certainly cleaner environment. And that's a 1 week post out there. So again, we're seeing very, very, very fast healing with that. So think about all your cases that have this in your office, and now we can do more than just, well, hope that plastic scaler does something. Now you can actually get in there and treat it. So in the case then of peri-implantitis, as we said, we're actually seeing more distinct bone loss in there. And so with that, we'll kind of probe in there. Now, in this case, you do have the option of potentially removing those implants and then flapping and cleaning everything up. In this case, the choice was made to just use Perio Guide to go in there and clean that out. By going into that same technique that you just saw and cleaning that out. But there certainly is an option in this case, in that radiograph on the left there, to actually remove those implants, put cover screws on there, and do like a PRF or grafting on there. In that case, what you're actually doing is using those implants as kind of tent poles for your membrane in there, and you'll get bone growing back around those implants. And in that case, you have an even better chance to directly visualize and fire the implant at all those threads to detoxify it. And you'll get bone growing back up around those implants. So again, not just avoiding it, you want to intentionally do it. You want to intentionally hit that. So down the line then on periodontal applications, we also would do just a little brief thing on crown lengthening here. Closed crown lengthening, think no flap, right? You're basically going into that pocket. So when am I, for Solea users out there, when am I doing one versus the other? And in this case, basically, you could look at it as if you have thin bone, like the facial, like what we saw earlier, thin bone on like tooth number 7, 8, 9. Those are great, but along the palatal, I would opt out for a wider spot size. So you're, instead of the smaller 0.25 millimeter spot size, the contra angle allows you to go up to 1.5 millimeter diameter spot size to treat those areas, to reshape bone in those cases. But you're still talking about fast healing, great post-op experience, and then very often going to the final restoration right away. And so the question is, well, how do we choose? And it's like kind of briefly said, it's like, well, if there's thin bone, think, lower left molar, you have thin bone on the lingual, you could do closed crown lengthening all day. Think about how tight that is against there. That is, dives down to the floor of the mouth. Now imagine that same tooth has a buccal exostosis, buccal tori. You can't, that's not thin bone anymore. I might need to visualize that a little better. But when it comes to that, especially interproximal is the tough spot. So in this picture here, we basically have, that interproximal, we have decay that goes below the alveolar bone, and now I need to remove that. So in this case, if you just remove in that section right in there, if you're just removing that bone, you just created kind of a pocket across there. So in those cases, I think it's better to flap. Now, you don't have to flap from the canine all the way back to that wisdom tooth back there. You could just basically laser across the papilla, pop the papilla out from either side so you can kind of visualize both line angles, buccal and lingual. And then with that, you can then kind of make sure that bone is equally reduced, as well as has a nice kind of flow to it for positive architecture for that. So that's kind of one of the benefits of flapping on that, where we're kind of limited. Now I did want to include this picture. I kind of alluded to this before. When do we have to really be careful? When does this push us almost assuredly to flap design and not closed crown lengthening, is when we don't have enough attached keratinized tissue. In that case, then we see there's almost a mucogingival defect here about to start. But side note, great, with the decay that's there, the great option for the laser for that. But in this case, if we were going to do crown lengthening, we don't want to vertically cut away that tissue because now we got a graft, right? Um, and so in this case, then you'd laser across the papilla, use like some kind of curette or periosteal elevator, elevate those papillas around. You don't have to elevate the lingual, and then use the laser to remove bone. Contra angle would work just fine here, and then suture everything back. And a note on suturing too, for all this would be great for like a vertical mattress sutures. Just put a little loop in there, floss it through, and tie it off on the other side. Don't forget to, I mean, so you don't have to get fancy, just don't forget to put the sutures on the buckle, not on the lingual. So your tongue's not playing with them. So here's Josh again here. I want to show you a couple anterior crown lengthenings at work. So here's where that facial bone is nice and thin, right? And as he goes in there, um, we're seeing where there we go. We're seeing where he's just kind of dropping in there. In this case, he's able to remove bone without necessarily removing gingival height. So we can keep those the same. You can see how far down that's dipping in there to do that. Um, in this case, obviously, because there's not a whole lot of clinical crown height to work with. So making himself a little bit more space in there. The nice thing then is if you end up restoring with things like lithium disilicate, Emax, or Katana, Zircad Prime, these zirconia type materials, is those are really good for tissue contact. There's a couple papers out there that show actually hemidesmosomal attachment of the tissue as if it's root surface to those materials. So side note on that, A, they're great. B, anything subgingival, don't glaze that part. Just a note on what he's doing at the end there is almost using this like the needle of a record. He's kind of just feeling in there, making sure he has kind of a nice, consistent bone reduction through there. All right. So let me show you then where the contra angle can kind of come into play here. I'm going to kind of skip forward a little bit. Basically, you can kind of see there where for this patient, these crowns were just set lower. The teeth were kind of emerged down. And so what we're trying to do is like the lateral incisors were up about 3 to 4 millimeters above the height of the crest of the gingiva was higher than where these teeth are kind of almost pointed down, like almost supererupted, and the crowns and the gums went with it. So now what I'm doing is using the contra angle kind of at an angle. And again, when you see a little bit of that flare up, that's where, like right there, that's where we're actually removing bone across the surface of that area. The technique with the contra angle is you kind of remove gums and bone until you get to the desired height. But then we know that with biologic width, if you just cut it to that point, the gums will grow back up and over that bone tissue. So underneath the gums, in between the gums and the tooth, that bone has to be reduced another couple of millimeters to you're basically recreating the pocket, and then that won't. And the nice thing with the Solea is that there's no heat here. So you're not cooking tissue like we used to with diodes. So you're not going to get further dieback, further recession. And if anything, where I'm sculpting this is exactly where that margin is going to be in a few days, much less a year later. And we have lots of case studies on that shows that. You don't need to go all the way to the palatal on this. The palatal is fine where it is. But you do want to kind of go in and make sure that you're going all the way to the line angles at the interproximal, just to make sure that pocket is consistent all the way across. And you can see, again, just to point out how much bleeding, or I should say, how much you don't see bleeding happening in there as far as this goes. And this is just the regular crown lengthening code as you go in there. So we ended up doing both teeth. Both teeth get treated. Um, I'll just kind of skip forward just for time because we're kind of getting to the end of our hour here with just about 10 minutes left here, and just sculpt it away. And then in this case, here's our kind of final post-op. It's already super clean in terms of being able to get in there now. And next step for us on this, we zipped off the crowns, scanned it, and then made 2 same-day CEREC crowns. Again, go into final restoration without waiting because of the predictability of that gingival architecture there. Okay, couple last cases, and then we'll take some questions. Don't forget about your Q&A button there. Go ahead and type in any questions you have, and also if you did have any suggestions of any of these topics that you'd like to do a deeper dive, we'd love to hear about that too. So anything you got there, I'd love to hear it. But yeah, extractions. I'll just kind of show you part of this video and then another cool case we got where essentially, in this case, I don't have very much tooth structure to grab onto here. So I'm kind of, how am I going to get that tooth out of there without kind of digging in there or flapping. So in this case, what I'm doing is removing some of the interradicular bone to kind of carve that back, which is then going to allow me to get, again, get in there and start getting a little more of a purchase point with your forceps. And you could do wherever you think you're going to need a little bit of that. You can see how much gum tissue is actually kind of like sponged over the top of that. And you'll see me just kind of cutting that away so I can get to it and get an elevator in there. Now, there has been some times where we've used it, we kind of kick up the energy a little bit and actually section teeth with the laser. Where, let's say you have a broken root tip down below, your 2 options are either do something like this to create a little space, and then kind of carve those out. Now I can actually get that root tip out. Your second option is if it's a smaller root tip and you have the time, you could literally, a minute or so, you can literally go in and just laser the root tip away. Don't forget, um, this actually cuts teeth, right? So just crank up the energy a little bit and just laser the root tip away, and then you're done. So last case of the day then is this other one. So we're going to do an uncovery here, and as well you see where there's a little supernumerary tooth, um, and we want to get that out of there too. So where that's covered over, now we have, again, metal close by. Doesn't, I'm not saying don't be careful, but if you happen to be coming at an angle where you happen to hit that, you're not going to arc or spark or burn up or heat or pop bonding or anything from that. Um, and so so you can basically just kind of start in that area, and you're going to do kind of a similar technique to what you just saw, is start with a painting motion, just kind of go over the top of that whole surface there, and that will essentially start exposing that. And when you start to see the tooth, just start moving outward from there. And so it kind of exposes the whole top. As long as you don't hold the laser there, it's not going to cut it. And then kind of clear out that tissue. Now that tooth has a nice eruption path, but we still have to kind of go over there and get that last little supernumerary tooth out there. So you can kind of laser, rather than necessarily retracting through, just kind of laser in and go down and find that and pull that out of there. And do that extraction there. So it kind of pulls that out, and now we have that little space that's left. So easy stuff to kind of carve around there with extractions too. So that's where we are. That's the kind of the encouragement to all of you. If again, is if you're already doing a lot of these surgical procedures, you have a tool available to you that is potentially going to like cut better, heal faster. If you're not doing these procedures, what a great way to kind of onboard on and sort of start doing more of these for your practice. in a way that's going to expand what you do, but like I kept saying all along, but not compromise any clinical results. If anything, this is better than what we would call all these traditional methods of doing this. Um, so thanks everyone. We're kind of getting to the end of the hour here. If there's any immediate questions, go ahead and type those in. But again, I would encourage you all to go ahead and check out some of the other, I mean, all the webinars on Viva Learning are just fantastic. As far as that goes, so much great content, but Celea specifically, and I have a few other ones on there. I encourage you to kind of go look at those because those also do a nice deeper dive into the possibilities for this laser. And of course, you can contact the company directly if you wanted more information or you wanted to do a little test drive in your office. So very cool stuff here. So let me go to the Q&A a little bit here. So let's see. Does it replace curettage? This is about half an hour from Audrey. Does it remove necrotic cementum? It does remove necrotic cementum. Does it replace curettage? If anything, hopefully it demonstrated in there that we actually do both. It's not just the laser. It's laser, then curettage, then laser once again. This is a little side question. Can the laser be used to remove amalgam? Also, could you describe the compound anesthetic technique they use? Removing amalgam, it doesn't really cut metal very well, but part of the reason that it does anesthesia-free cavity preparations is the laser is actually pulsing on the tooth about 1,100 times a second, and that pulsing creates an analgesic effect that, for all intents and purposes, shuts the nerve down. So when we do amalgams, we'll start in areas of leakage, kind of start troughing around the amalgam, and then literally pull a handpiece out and cut it out. Now the amalgam is gone, and then you just basically go back through and finish up your entire thing with the laser. So the compound anesthetic technique. The Monoject makes these little syringes with like a luer lock, a screw-on tip, and then we use the Ultradent little Endovac tips, and basically with our compounded topical, fill up the syringe and then screw one of those on there, and that does it. It's awesome. And so you can kind of noodle in that little flexible plastic tip anywhere you want. I do a similar technique when we start looking at like a operculectomy. The operculectomy technique is I'll take that little tip and kind of go right underneath there and then kind of syringe that around. And then that's all the anesthetic I need for something like that. So again, we're kind of getting away from using the actual needle. Let's see, Dr. Grant Selig, how you doing? He just has a comment, been using CO2 for corrective implant cases, especially on medically compromised patients and carbo with no epi. Absolutely, those are great. What I would also encourage you on any of those, medically compromised cases or in those actively treated cases where you have like, cancer patient, they're undergoing chemo, radiation, there's exposed areas of bone, and you get necrotic bone, you can absolutely go in there with this laser and remove that too. So it kind of exposes that new layer and lets the tissue kind of do a little granulation right across the top. It's awesome. Quick question on that case with the supernumerary tooth. Would you also be putting bone and a mesh? Younger patient, that small defect like that, probably not but no reason you couldn't on any, like on a general extraction where you're doing, and you want to do some ridge preservation, 100%. In this case, we know the bone is not lower than where the DEJ, the CEJ is of the erupting tooth. So that bone, as that tooth erupts, that bone's going to fill in for that. quick question on do we use it on oral aphthous ulcers all day long? There's a setting that you can switch it to kind of a no water mode, a dry mode, and it's like doing a laser band-aid on that. Um, by the way, uh, there's a funny comment from Cliff that says, I forgot my question. They all have Viva's got my email and all that. If you guys come up with anything, later, if you want to, definitely, this doesn't have to be the end of the conversation. So keep that going. And to that point, sorry, one more question here. Is CO2 laser better than a resin in each site? Yes, because it's not just doing antibacterial treatment, you're actually removing granulation tissue, stimulating healing, that photobiomodulation effect, all that. So awesome stuff. So, well, thank you, everyone. It's been great being able to spend the hour with you. I hope you learned a lot. Looking forward to the next Viva Learning webinar with you all. We'll chat with you soon.